Okay, well I think we are all ready to go. I'd like to welcome everybody tonight. My name is Monica Hartung. I serve as the chair of the Community Relations Committee as part of the foundation. So this program is kind of brought to you from that committee as part of a larger set of programs that we've offered this summer. So our first part of the series was Medicare Simplified. That took place in August, and that was a lot of information about all the different options there. Then we have this called as part of Covered and in Control, the Advanced Care Planning Seminar tonight. And then we have another one coming up in the fall in October called My True Advantage. So that is another piece of this, and we do have stuff out there that you'll be able to pick up later. We do want to welcome you on behalf of the foundation. Housekeeping stuff, garbage is up here, restrooms are out the door and to the right. Food is still out there, so if you need any of that kind of stuff, it's all located out there. Just kind of want to introduce you to the evening here. So again, this is the Advanced Care Planning Seminar. Just kind of a brief overview. You have packets in front of you that have all kinds of information in there. So we're just going to be kind of moving our way through this with different presenters tonight. You don't need me to read it to you necessarily, but we'll be talking about understanding what an advance directive is, what are the elements of that, how do you do that, and then kind of moving through some other pieces of this. What is palliative care? Talk a little bit about hospice care, and then we have a panel discussion for you later. So the way the evening will kind of move through is that we'll have, I think, 4 presenters here, then we will take a short break, maybe 10 minutes, and then we'll have an opportunity for a panel discussion. So you have little buckets on your tables with small pieces of paper. So if you think of something that you want to ask throughout this session, just jot it down and throw it in there. We'll collect all of those during the break and be able to ask those of our panel afterward. Can everybody hear me okay? We do have a mic, but is everybody back there is good? Okay. Yeah, so I think that's kind of the general format for the evening. So the first speaker this evening is Dr. Ryan Stone. He serves as the CMO or Chief Medical Officer here at Schneck. He's also a hospitalist, so he brings a unique perspective. So, Dr. Stone.
Thank you. All right. Good evening. Thanks for being here. We appreciate your attendance. We hope to be able to share some good information with you here tonight. My portion of this evening is going to be really kind of talking mostly through the advanced directives and what they are and how we use those in your healthcare. So I want to talk briefly, just to kind of give you a quick definition of an advanced directive. These can be a little bit unnerving, I think, to have conversations around. And so our goal tonight is to try to demystify some of these and try to take some of the scariness away from some of these conversations. These advanced directives help to guide us as your medical care team in what your care looks like. And how that really, that conversation helps to transform this whole process from a treatment standpoint. The advanced directives can be legal binding documents, so some of them are completed between you and your attorney or lawyer. Others are actually legal binding in the fact that it's between you and your physician. It becomes an order, a physician order for care. And so, again, being legally binding, once you've had these conversations, you fill out these forms, we keep those, you get a copy of those. They help to kind of transition through your care, whether that's in the outpatient world or in the inpatient world when you're admitted to the hospital. So it gives us some opportunity. But there also can be updated, and Dr. Hartung is going to kind of talk through that a little bit as well. So once you do one, doesn't mean it has to stay like that forever. You have some opportunities to keep things updated from that standpoint. In the state of Indiana, we have really kind of 4 that are the most common types of advanced directives. There's the Indiana Healthcare Representative form. So in your packet on the left side, I think, of the packet, we have a copy of the forms for you. So there's the Indiana Healthcare Representative form, the Indiana Physician Orders for Scope of Treatment, or what we call the POST form. The last 2 we do not have a copy of. So this is the out-of-hospital DNR. This is an older advanced directive. It is still used, but just not as widely. And the last one is called a living will. And so we're going to kind of talk through a little bit of this. I think there might be a graph somewhere. Yeah. So this in your folder kind of walks through these different 4 different types of advanced directives. It gives you a little bit of information about them. So the Indiana healthcare representative or power of attorney or proxy form allows you to nominate or to designate somebody to be your person to make medical decisions for you in the event that you're not able to make those decisions for yourself. So what that means is if I were to come into the emergency room and I was unconscious, I couldn't tell the providers what my preferred treatments were, that whoever I have designated as my healthcare proxy, they get to make those decisions for us, okay? That does not mean that they can make decisions all the time. If I come back out of, or back to consciousness and am able to interact, that healthcare proxy does not make medical decisions for us at that time. So the healthcare proxy is only utilized when the patient is not able to make decisions for themselves. Does that make sense? The next option is the physician orders for scope of treatment. So there's also a copy of that. This is let me back up before I move on to that one. The healthcare representative form. That is a legal binding document. So when you sign that document, it can either be notarized, so you fill it out and have it notarized by somebody, or you can fill it out and have it witnessed by 2 separate individuals that are not listed as your healthcare representative, and it becomes a legal binding document. Okay, so that can be used anywhere for your care, whether that's outpatient, inpatient, that follows you from that standpoint. In this next document, the physician order of scope of treatment, this is a physician order. So this is where the conversation between you and your physician comes into play. This conversation walks through this entire order. So it talks about what is your resuscitation status? What does it mean for you when your heart stops beating or you stop breathing? What do you want us as your care team to do, right? So it talks about the use of CPR, ventilator, medications, using a defibrillator to shock your heart back into rhythm, those kinds of things. The next conversation is how aggressive do you want us to be in your overall care? Do we want to do full interventions where we're doing everything we can to kind of cure whatever is going on? Or do you want to be more comfort focused, where we try to really just keep you comfortable and allow the natural dying process to occur from that standpoint? It talks about artificial nutrition, whether or not you would want to have artificial nutrition or not. It also gives the opportunity to say how long you want that artificial nutrition. Do you want antibiotics to be a part of your treatment plan? And any other options that you might want to add in there from that standpoint. Once you have that conversation with your provider, they actually sign that order and it becomes a living order moving forward. Just like if they were to give you a prescription for a medication, that becomes a living order for your care moving forward. The next one is the out-of-hospital DNR, or DNR stands for Do Not Resuscitate. This is oftentimes used for folks that are severely debilitated and have the propensity for death because of their illness. Meaning, if you were going transitioning from the inpatient world and you were going to go home on hospice, we would typically fill out an out-of-hospital DNR form so that if something were to happen during the time that you were being transported back home, that you would not have to be resuscitated, that you could be kept comfortable from that standpoint. Again, not as highly utilized nowadays, but it is still a form out there available. The last one at the bottom of our list is the living will. As a show of hands, if you're brave enough, who has a living will? Okay. Lots of people typically have these, and I will tell you from a physician standpoint, it's probably the least helpful in your care. So the living will typically only states whether or not you want artificial nutrition. They usually don't go into much depth of how your care actually looks, right? And so from my standpoint as a hospitalist, when I'm meeting people that are super sick in the hospital, the living will doesn't really do much for me when I'm having to make the decision of what's our next step, right? Now it does help to kind of understand a little bit maybe where people's initial thoughts are for their overall care, but it doesn't spell anything out. So there are lots of people that have living wills, but oftentimes we will ask for additional conversations, and we'll encourage to either have a healthcare representative or a post form filled out in addition to having that living will. Okay? Questions about any of that? Stephanie?
What happens if you're at another facility?
Great question. So we always give you a copy of these forms and encourage you to keep a copy of these if you're going to another facility. In current state, there is not any great way for these documents to travel to other facilities with you. If we know that we have a copy of it and we're going to be needing to transfer you to another facility, we'll make a copy of it and send it with the packet and with the patient. But if you get your care here and you get care at another facility, you want to make sure that anybody that you're getting care from has a copy of that those documents. Good question. Yes, ma'am.
For out of hospital DNR, is that typically, or are you talking about an ambulance when you?
Correct. Yep. 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 Yes.
I don't know if this is the right time to even ask this question. As a physician, if you had somebody who had designated her as my healthcare representative, but my family was like having a fit because they didn't like that, you follow what she says or
Absolutely.
what my family says?
We have to, legally, we have to follow what the healthcare representative form says. Yep. Yep. Whoever is designated, that's a legal binding thing. We do run into that on occasion, but we just very plainly state, this is a legal binding thing. It has the patient's signature on it. We have to go by what they have designated. So, great question. There was another hand raised. Yes.
Do you take it to your physician or to the hospital or?
Any place that you get care. So if your care is all right here at the hospital, you can have it just one copy of it. We'll load it into your chart. If you get care at other facilities, whether that's outside of Jackson County or even up at a family medical center, I think, Dr. Pam, you may be able to speak to this. I think we share some of those forms back and forth when we see those come across, right? But outside of Jackson County, it becomes a little bit more difficult to share that information. So, I kind of walked through a little bit of this already, so talking about the designation of the healthcare proxy. Is this still me or is this Dave? I think so, right? So you want to make sure that you don't just nominate somebody and without having that conversation with them, right? The whole point of this is so that whoever you nominate to be your healthcare representative, they understand what your wishes are because they have to act in your stead, right? What I want to happen may not be what you want to happen, but we have to follow what you want in this case. And so that's why we have to make sure that everybody's on the same page when you're picking that designee and they understand exactly what your wishes are from that. The values, goals, and regarding quality of life. This becomes a very big conversation, and Dr. Hartog is going to kind of walk a little bit through this. But these are oftentimes long conversations and maybe sometimes distressing conversations. Not a lot of us like to think about death and dying. And what I say is, I don't like to talk about that either. But I do want to make sure that I'm comfortable in that. And so that's why we have these conversations, right? And so making sure that your family, especially your designee, understands what you value in life. Is it quality of life versus quantity of life? And what does your care overall look like? Do you want to be on life support? Would you rather just be comfortable? Do you want something in between? What does that look like for you? Okay. Here's the comparison that I already showed you. And with that, I will turn it over to Dr. Hartog, who's going to walk through a little more discussions about how to fill these forms out.
Thank you, Dr. Stone. Again, my name is Dave Hartog. I'm a family medicine physician here in town for almost 20 years. It's shocking to even say that out loud, but That's how long I've been here. And I was asked to give this part of the conversation because I've had these conversations many times. But as Dr. Stone will tell you, not enough. This is a hard thing to talk about, and it's something that it's hard to get people to come in and do these kinds of paperwork and discussions and whatnot. So I'm here to basically kind of walk you through a little bit of what I do and what I say to patients, and make it a little less frightening, I hope. Because what we're talking about is end-of-life care. This is those discussions for those times when you are closing in the end of life or something happens, and you have decisions and you have things that you want done, but people might not necessarily know that. And so we're talking about end-of-life care medical ethics and what to do when your decisions can't be made for you. So going to a little bit of background, Monica and I met at Notre Dame many years ago, 30 now, and we had our favorite class our senior year with Father Jim Foster. He was a priest who taught medical ethics to us, but not only was a priest, prior to his priesthood, he was a physician. He left medicine, whatever happened. He never really told us why. But I think he had a calling and he became an ordained priest, and he taught us medical ethics. So it was a wonderful experience in end-of-life care, right and wrong and whatnot. But one of his favorite things to say is there are no wrong answers, and that's something I'll express many times throughout this evening. This is an individual choice. This is your personal beliefs. I think this slide says it. Get it? Nope, not one. Personal goals and personal values. And so I want to make that clear that whatever you decide with your physician, lawyer, family member is not wrong. It's based on your beliefs, religious beliefs, scientific beliefs, whatever they are. So as I kind of guide you through this, I want you to remember that nobody else should necessarily make these decisions for you. You can get opinions from your personal physician, you can get opinions from your family, but at the end of the day, it's what you want at the end of life when you can't make those decisions. So when I'm giving this little speech of mine to my patients, I often bring up how different people can be, how disparate views are about the end of life and what do you want to do. And my story is my dad and his family. So my dad is one of 5 siblings. There was a girl, then there were 3 boys, my uncles, and then another girl. And so my 2 aunts were the bookends of this. And their views of the end-of-life care were completely different. My aunt, the oldest one, would say, it's my time. If something happens, this is not what I want. I don't want to be here. I don't want to be on a machine. I don't want any of this stuff. Just let me go. Whatever it is, I don't want it. And, okay, very clear, right? The youngest child, also the other sister, said, you will hook me up to every machine this world has. I want everything done. You'll give me every antibiotic you'll put a breathing tube, you'll do everything. And they could not have been more different, even though they're, again, my dad's 2 sisters. But it taught me a lot about just how personal this decision really is, and what it means to people when you start to really think about, what do I want? What do I need? So it's really about those personal values, those goals. And it gets on to the question of when Dr. Stone's talking about a healthcare proxy. Somebody that shares those values, somebody that understands what you want in the situation. And I wanted to point out in your packet, it pulled this out for me, Indiana default surrogates. Most of this stuff is state dependent. And that's very important to remember if you move to Iowa or Massachusetts or whatever. Everybody's got their own individual state things. This one specifically says if nobody knows, who do we ask? And so you see, it goes from your spouse, if no spouse, to your adult child, to your parent, to your adult sibling, to your grandparent. So it has Indiana has a very specific guidelines of how they do this if you don't choose who you want to make your decisions. So that's an important factor of why we're here today. Choose somebody, pick somebody that you trust. And that does not have to be your power of attorney. There's always a confusion is, my power of attorney does everything. No, they can do your checkbook, they can pay your bills, they can do all that stuff when you can't. But your healthcare power of attorney is specifically different, and they can be the same person, and that's fine. But often people will have a business person in the family, and they'll have a medical person in the family. So just important to know that those are different things in different people. But if you do not choose, there is a hierarchy of how this is played out. So, Medicare's interesting because you turn 65, you go on Medicare, and they kind of treat everybody the same. Not really, but a lot of it. They love annual wellness visits, whether you're 65 or whether you're 95. However, that's an entire generation when you think about it. Their Medicare beneficiaries are not the same. And so just a reminder that as you go through this, if you are 50, if you're 65, if you're 75, 85, your life circumstances will change. And it's important to review this every now and again and update it with your family, your physician, anybody. As long as people know your wishes, if everyone agrees, this is never an issue. I did inpatient medicine before the hospitals program started from 2005 to 2012, and I had the scenario where the cousin flew in from Texas and they blew up the whole scenario. The person was intubated, the family said, no, we're done, this is futile, we don't want any more suffering, and the cousin came in and it was a absolute mess. So as long as everyone agrees, all of this stuff is actually pretty straightforward. So what we're going to do is go through the post form. If you want to pull that out, it is the Indiana Physician Orders for Scope of Treatment in your packet there. And Dr. Stone and I have had this discussion more than once about how much we like this form, how much we like A, B, C, and D, how much we like things to be on one page. But the caveat to that is the second page, this is actually more for your more critically ill, a little bit later stage of life kind of people. But I have used this form for people in their 50s because I just love the way that it lines it out and really kind of helps me to explain to you what we're talking about when we talk about these end-of-life care decisions. So, again, when I'm going through this with patients, it's easy. We start with A. A is the classic DNR, do not resuscitate. Everybody knows DNR from movies and TVs for 50 years now. They've been using that phrase. But what does it actually mean? It means if we find you and you are not breathing and you don't have a pulse, now what? Do not resuscitate. And I've had people tattooed on their chest, and then that wasn't enough because it wasn't signed, so they tattooed a signature. I mean, it gets a little crazy. But that was a true story, actually. DNR means we do nothing. Your wishes are, which is my oldest Anna, that it's over. I don't even try. I don't care what's coming next. If I've had a stroke, if I've just passed out, if I'm not pulse, no breathing, I am done. And so if that is true, the fact this is the classic DNR. Do not attempt to resuscitate me, or yes, please try to bring me back. Try to do whatever you want, which could include shocks, which could include chest compressions, which are honestly quite brutal, which includes medicines and things that the EMS would do out there in the ambulance, which gives rise to follow up on Dr. Stone's out of hospital do not resuscitate order. It's kind of fallen by the wayside because it's so hard to enforce. If a paramedic finds you, they're going to do stuff. I mean, it's just unless they know it. Again, you have it maybe tattooed up here, maybe, I don't know. On the chest might be a bad idea, but those have just generally not come in favor. Now, if you're in the hospital and you're very ill and your heart stops, okay, then we've got a better idea what's going on. So section A is simply yes, bring me back, or attempt it, or please do not. Section B gets really into the nitty-gritty of, okay, I've come back to a certain extent. I have a pulse. Maybe I'm breathing. Maybe I'm not. And there's three boxes there, if you notice. But really, it's the top and the bottom box. The top one there is I just want to be comfortable. You brought me back. I got my heart beating, but this is not going well, and I don't want to be prolonged. I want to be comfortable. I want you to address my pain. I want you to address my anxiety. I want you to just do the things that are going to make it easier for me to allow the natural dying process, which is a scary term, but really underscores what we're talking about is just help me out here. Kind of like a mini hospice at the end of life. The full intervention at the bottom is, again, my youngest aunt. Every machine you've got, I don't care what it is, hook me up to it and keep this thing going. So the middle ground there is really what we used to call a DNI, do not intubate, which again has fallen kind of by the wayside as not a very popular term. because people will tell me all the time, and they'll say, I don't want to, just don't stick that thing down my throat. I don't want that machine. You know, I don't want it breathing for me. That's just going to prolong the suffering, blah, 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 or whatever. And I get what they're saying, but then I say, what if you have pneumonia? And you're gonna breathe free for 2 days, and I'll take it out. And they go, okay, well that's fine, you know? And I say, well then you can't write do not intubate. Most people, to sum up the whole evening, quite honestly, not really, but most people, when they get to this conversation with me, say the same thing. They say, please do whatever you can until it's obvious that this is not going well. Then please stop. You know, whether it's, you know, clinically brain dead, whether it's abnormal suffering, whatever, pain. Most people say, I want most things done. My aunt who doesn't want anything done is really the exception. But my aunt who wants everything done is also. So people want to be, they want to give modern medicine a chance. But if it's very futile, or obviously futile, please, you know, cut this out. So Section C there and Section D are simply antibiotics and artificial nutrition for treatment goals like I want to cure your pneumonia or I do not. So most of the time people fall into that category. If it's obviously comfort measures or obviously full intervention, then yes, I want antibiotics or no, I do not. But antibiotics can be a comfort thing when you think about pneumonia. It's not very comfortable. So even sometimes if you're allowing the comfort process to take, yeah, still give me antibiotics if it might improve my situation. Artificial nutrition, almost everybody says the same thing. I don't want that unless it's only a very short a time. So this form allows you, if you see on the defined trial period, to say, do it for a while. Give me a shot. If I can't eat and I need nutrition, feed me for a little bit. And usually we're talking about a tube that goes through your nose and into your stomach. Longer term can be a tube that goes straight through your skin into your stomach. But this gives you an idea of you know, how long would I want this to go on. But this is an important point and worth making at C and D, where we talk about things can change. These forms are your wishes, they're your opinion. But if you're in the hospital and you've had a feeding tube for 2 weeks and they're like, we got to put one here, and your form says 2 weeks, they're not going to be like, 2 weeks, man, you know? Then these can change, and these can change via your healthcare proxy. So this is why it's important to have somebody that shares those goals. Because if you can't answer that question, you need somebody that can answer it for you. And that's it. That's A, B, C, and D of the post form. The second sheet, if you're looking at it, just simply where you sign it, where I sign it, where your person to sign it, if you have a representative, is all really that second sheet says there. So that's really it, I think, is what I wanted to talk about. Any questions for me? That was a lot, wasn't it?
So there really isn't a way, though, based on your example, where if someone says, well, I want to be intubated if I get pneumonia, but not if I've been in a massive car accident.
Correct. There's not. Well, now, I take that back. So a living will, that's again more of a legal document, can say anything you want it to say. It can specify. I mean, but as Dr. Stone's pointing out in my memory from being inpatient medicine, it's hard to find those in the moment, in the ER, in the whatever. And then there's plenty of examples that we've both had where patients are brought to the emergency room and they are resuscitated for 45 plus minutes. Then somebody finds this and they go, oh, I'm not supposed to do this, and they stop. But yes, a living will could designate length of treatment. I want, you know, if I'm clinically brain dead. Actually, on the optional, so again, me using this form a little bit off label, that optional additional orders I often will have people add at their discretion, may cease care if determined to be medically futile. So it's not really on the form, but we kind of add it in there. So good question though. Again, this form I use for probably more people than I'm supposed to, but it is really one of the better forms I've found, and it is Indiana specific. All the states have their own forms, so I think Indiana's come up with a very, very good one here to again talk with your personal physician about.
Does the hospital representative, or if you check in to the inpatient or in the emergency room, do they ask, do you have like these documents or living will?
Yeah, They should go for, there's a specific spot in the electronic medical record where these forms are stored.
But if they don't have it in there, if you've got it, but they don't have it in
Yeah,
there.
if you can respond, and this is the issue. So if you have the healthcare proxy available, that becomes part of, and Dr. Stone could attest to this, the tricky issue of we can't find any of these forms. What do we do? They're going to default to resuscitation until they know for
Well,
sure.
I'm thinking of an example. My husband had to go in for some kind of procedure, and I was focused on getting him there and, you know, all these other
Yeah.
things. I did have it in the car, but, you know, because they asked, do you have this
Yeah.
document? Yes.
Wait,
I'll
just-
just take him and then I'll go get it.
Wait right here. But it is one of the reasons we always stress trying to get these documents once completed to as many locations as possible because of the interoperability of the systems. We don't really talk to Columbus and the computers and all this stuff, but anywhere people think they might be is an excellent one.
Anytime that you're admitted to the hospital, that is one of the standard questions that is asked in the admission process. Do you have an advance directive? Do you have a copy with you? If not, then let's try to get a copy of it so that we can have that. If it's with your primary care doctor, then we'll try to reach out to them to try to get that as well.
Because I've had that with my husband. I'm more focused on making sure he's taken care of and then, you know, giving them the documents is secondary to
Absolutely.
making sure he's okay.
And hopefully, you know, once it's in there, then it's in there. Outside of those regular reviews and whatnot that we do. So, all right, I will hand this. Oh,
Next question.
Can you submit these forms to the Schneck portal?
That's a great question. We started a brand new electronic medical record system August 1st. Nobody knows anything.
I know, I started to fill out a questionnaire, so
We're struggling.
It will be. It is not available currently, but it will be something that in the future we'll be able to accept those through the portal.
So everybody knows, hospitals work on Meditech, is the name of the company, from 1999, which is pretty cool as a family doctor. I can go back and see your mammogram from 2004 or an x-ray from 2002, but it was time for an upgrade. The upgrade literally just happened. So yes, I think that all of this stuff will be available. That's an excellent question.
Was it you that was talking about the power of attorney being different from the
Yeah,
healthcare process?
can be, doesn't have to be.
Okay, but if it is, can the power of attorney overrule the healthcare proxy for any
No.
reason, financial reasons, anything?
Nope, it's a great question. Is healthcare power of attorney, as Dr. Stone was saying, legally binding, completely separate? It's often the same person, quite honestly. Probably most of the time it is the person you trust with your finances, the person you trust with your healthcare, but they cannot do that. And again, these scenarios where these people swoop in from out of town and demand this, that, and the other is the entire reason that this was created. Wonderful question. And we'll have a panel later to answer all the other questions. That'll be great. All right, I'm going to hand this over to Dr. Fisher. I think, right? Yep. There she is. Talking about palliative care.
Hi everyone, I'm Dr. Fisher. I am a hospitalist along with Dr. Stone, but then I also work part-time in the Schneck Internal Medicine Clinic as a primary care doctor there. I've been asked to talk about palliative care because it's something that, you know, over the years is a need that we found in the community, and there's been times of trying to establish a program for palliative care. COVID definitely gave a hitch to that at that point in time when they were trying to do it a few years ago. And so something that we're trying to get more information on, get more training and things like that. The other reason I've been asked to talk about palliative care is when you hear the word palliative care, people automatically think hospice. They are, I like to describe them as sisters, not one and the same. They're not twins either. So they're sisters because they both value one big thing, and that's quality of life. And so when we define palliative care, wrong way. The big thing for that is it's a medical specialty for people with serious illness, and this is at any point during their serious illness to help maximize their quality of life and help to support them and their family members throughout this. So when we talk about the key features again, palliative care is looking at the whole person. So not only physical symptoms, but also emotional and spiritual symptoms. Because if you think about at any point in time, the serious illness is a big hardship. And it's not only a hardship for the person who is experiencing this, but also their family. And that's where palliative care and hospice can be very beneficial in creating a support system for patients. Now, really good primary care doctors, such as Dr. Hartung, do a lot of this stuff in their clinic also. But this also gives another layer of support for patients, their families, and the primary care doctor to have another person watching out for the patient. It is definitely a team-based approach, so just like hospice, there is usually a social worker involved, a chaplain, a palliative care provider, and that way we can try to, hit all levels of what is happening. And the big thing to remember is that it is given alongside curative treatment. So when we say that, that means you can be in a palliative care program if you're undergoing dialysis. If you are somebody who is undergoing a heart transplant, you qualify for palliative care. Just because, if you think about undergoing a heart transplant, that is a big emotional toll, big physical toll. Think about the time that's spent in the hospital, the family that's there at the bedside, and then even afterwards, thinking about the immunosuppressant drugs or the drugs to keep your immune system down so you don't reject the heart. Those can cause a lot of symptoms for a patient in the long term. And so how do we try to manage those symptoms that these medicines that we need are causing? And so that is also palliative care. So I've kind of already touched on who benefits. And when I say this can be given at any point during a serious illness along with curative treatments, I want you to understand that there's even pediatric palliative care. So even kids that have cancer that it has a very good cure rate of 90+%, they receive palliative care because, again, they're undergoing treatments that are very distressing to them. Their family members and their parents are taking care of them. And so having that extra layer of support, like I said, from a physical, mental, and spiritual standpoint is very helpful in working through these. So the overall goals is to manage symptoms, and that does include pain. So if you think about cancer-related pain, that's a big one. I've had a patient say to me before that their big goal in their daily life was to stand up straight to brush their teeth in the morning. From chronic back pain from lots of accidents and because of the shortness of breath that they have from their severe COPD. So somebody that would benefit from this is somebody who's on chronic oxygen with COPD that gets admitted to the hospital a lot for exacerbations and doesn't want to be there because nobody wants to sit with us in the hospital, even though Dr. Stone and I are delightful. But, you want to be at home. Everybody wants to be at home. And so palliative care helps to try to keep people in their homes where they're comfortable to maximize their quality of life. Patients with heart failure that have fluid around their lungs or their legs or even their belly sometimes, trying to keep them out of the hospital so that they can stay comfortable at home. And so those are some of the symptoms that we can treat. Like I said, the emotional and spiritual well-being is a very big part of this. If you think about a person with dementia and think about the stress of when they have to move out of their own home or when they can't drive any longer, that causes a lot of turmoil, that loss of independence. And family members hate that. It is very distressing to the family members and the patient. And so this gives an area to kind of talk about some of these things. And honestly, sometimes for us medical providers to be the bad guy so that the family relationship can stay together. So, so that can also be part of this. And then overall, like I said, it's about quality of life. Like I said, palliative care and hospice are more like sisters. So they both value quality of life, but they both have their own paths. However, they still kind of stay in the same family. And so the big thing that I want you to take away from this short talk is that palliative care is about quality of life and what you want as a patient and how you want your treatment and your life to be during a serious illness. And that can be, like I said, at any point during that serious illness. And so from there, I'm going to give it over to Rachel Fuller, who is our director of hospice here. and it's a program near and dear to my heart, and I think it is something that is wonderful for our community. So, thank you guys for all being here. My name's Rachel Bullard. I'm the Director of Home Health and Hospice. I'm just going to tell you a little bit how I got to where I'm at, because I never thought I would be in a leadership position at the hospital at all. I was going to be a bedside nurse my whole entire life, and that was that. But I spent 14 years in the emergency department, and I got to see a lot of death and dying in different forms. I see some folks here today that I think I took care of their loved ones in the emergency department when they passed. And what I came away with from those experiences, and I think Dr. Hartung touched on it, the emergency department is not the place to make these decisions, because they're going to do everything they can to keep you alive. And if that is not where you're at in your journey, you need to be prepared so you can guide that team to do what's necessary. So after I saw this and experienced this, I thought, there's a better way. And what I've learned is hospice is a really nice alternative if you are not wanting to pursue curative treatment. And so as my career came on here, I've been here for 20 years, I found that this was where I needed to be. So I'm very passionate about hospice. And my own experience myself, my brother had Duchenne muscular dystrophy, and he passed away at the age of 33 after care under hospice, and that was a great experience. And my father also passed here under hospice at Schneck. So we put together some testimonial videos, some stories from some of our patients and their families that have had hospice care. So I'm going to kind of let that tell the story for you guys. I think you'll find it really nice. Oh, I'm going the wrong way too.
I knew that she needed someone to help her. It seems like these people are friends when they first come in the door. And I think that's what I saw, that it wasn't, the emphasis wasn't putting on dying, it was putting on living. Putting on, let's get through this, that we're going to be all right, we're going to help you.
Hospice is concentrating on quality of life. They must have a diagnosis that meets criteria, and that's a medical guesstimate of 6 months or less. And of course, that is usually decided upon with their primary care physician, because they know them best. And as symptoms are not as well managed as before, that's when we can be considered. And then we come in and make sure that the patient has symptom management. And oftentimes they do so much better after their symptoms are managed. Studies show they live longer on hospice with symptoms managed well. So Janet is thriving, as you can see. And so that's when we want to get patients on hospice, not when they just have a few days or weeks left. And oftentimes we get them when they are in their dying state. So this gives us opportunity to help a family for many months rather than just days or weeks. So this is an optimal time that you have chosen this kind of care. And as you can tell, I'm blessed to be in here with this quality of family and of Janet's sweet demeanor and Bob's awesome support and the family support of both of them. I'm the blessed one that gets to come into this home weekly and make sure that she's as comfortable as she can be. Yeah, we all, as we age, we all will have a condition that deteriorates. And that's either congestive heart failure, a cancer condition, a dementia condition, a neurological issue, strokes. So when those symptoms are not able to be tweaked or managed with any improvement with a primary care physician, or when it's challenging to manage those symptoms, that's when a primary care physician could think about hospice, or a family member could call us and ask, hey, can we receive your help? You know, we need help to manage this condition, and please come and see us and meet us and see what you think, and we can be there to do an assessment.
Things that we didn't know we needed to do, they did for us. They had it all, I think it was, from the doctor's office and their coordination with hospice. They got the bed in there for us. They got the meds for us. Then they, told us how to administer the meds. Then they come and they came and they did the care for him, the cleaning. Mm-hmm. So I felt like the connection between the doctor's office and hospice was just on point, because we didn't have to do anything. We
It
didn't
was
have to make
fair.
any other kind of phone calls. It just was done for us.
Angels.
Yep. No wings.
Yeah, they were fantastic.
Yep, they were. As soon as she passed, they took care of calling everybody that needed to be called.
Yep. People that show up with hidden angel wings and
Oh,
take
but
care
it's-
of everything, it's just absolutely fantastic. I'm unaware of a negative stigma. Because if there is, there shouldn't be.
I would hope that someone would say this is for care. It's not for death. It's more for life and care.
Yeah, caregiving to a dementia patient, loved one, wife, is extremely difficult. It taxes the family and the primary caregiver, like Bob, tremendously. So it's so rewarding for me to manage behaviors with terminal illnesses because it just allows for quality of life and it gives the family much support. So that's why I keep doing it after 17 years. I just love symptom management and what it means to family members and to patients like Janet. So Janet and I go for walks. We go and look at her daffodils that are coming up. And we go down the road to look at Amy's house. We never found it that one time. Just like, it's down there. I had the wrong shoes on though, so we had to stop and just talk.
Yeah.
But yeah, you do not need to be in the house and you do not need to be homebound. You can take vacations, you can go visit family members. We want you to go to the reunions and the birthday parties. We want that because that's quality of life. But again, we want to take care of you now, your family member now, so we can manage those symptoms and they can have a better quality of life and make it easier on the caregivers, on the family, to have a team of people that will help them.
The things that I see is, like I said before, I was coming in and trying to mop the kitchen floor and do all the stuff, and I didn't get to enjoy my mom and dad. And I would see that every time I'd go home, I'm like, when I go, I have to do X, Y, and Z, and then I'm missing out on the little things that we get to do, taking little trips or drives to go get a orange high C at McDonald's, or, you know, I was missing that because I had to get the laundry done, clean and mop the floor, and Mom would help me, and we'd try to have that connection, but I was missing out on my parents because I was trying to do all the stuff that they needed help with. And so now, with some light cleaning and stuff, I get to spend time with them.
A lot of times with symptoms well managed, they may live for years. And we've had patients that's lived on hospice for 2 to 3 years because every recertification period, which is 2 or 3 months, depending where they are in the process, they still meet their criteria, the hospice Medicare criteria to continue. They still meet the criteria for their specific disease process. So oftentimes we have them for a long time. They can always choose to go off of hospice, but honestly we don't have that very often because the people, the patients and the family, the caregivers, really enjoy having nurses coming to them to help them with their terminal condition.
And I think that's where hospice is. They're not just here in the last days. I feel like she's gonna be here for Dad 2 years from now, checking in. That's what hospice is. And I didn't know that.
But those are moments where they were that calming reassurance that we needed, that we didn't know that we needed. And it was a carryover from leaving the doctor's office into our home. And that's where I said, it's not clinical. It's not, someone giving you this outcome, this diagnosis, the prognosis. It's this real life conversation that, they're able just to give us that support that we needed in that moment. So
You don't get that in Indianapolis. You're not going to get that in a big suburban hospital. You get that at Schneck.
It's the people.
Yeah, 100%. If you think hospice is going to be a difficult decision, it is. But understand on the back side of that, hospice is actually the single greatest thing you can do at that critical point in time for your loved one, in my opinion. And if you trust the people at Schneck with all of the medical care that leads up to a hospice decision, continue to trust them. Just continue to trust them.
We know we're gonna die, everybody's gonna die, it's just the way it's gonna be. But let's talk about what we're doing while we're here, and that's what they kind of brought to our family.
So I think that each of those different families had really powerful perspectives on what it's been for them, and I think that what you hear in a theme throughout this is it gives you some control over a very uncontrollable feeling, and it also lets you decide. It focuses on comfort. It really is a gift. So, with that being said, within your packet, there's a copy of the frequently asked questions. It's also available on the Schneck website that goes over the particulars of what hospice services is about. I touched on this briefly, why use hospice. It's really about gaining control about a situation and shifting the focus over from curing to caring. So that's really why when you feel the time is right, you should come over to hospice. And again, I think Dr. Hartung, it's very much an individual decision. Hospice may never be right for you, and that's okay. That's perfectly fine. But if it is your mindset, know that we will help very much along that journey. We have doctors. Dr. Pam is our Dr. Pam Schneck is our medical director. She works closely with all the plans of care for our patients. We have nurses, very experienced nurses that have been nurses and have done hospice care for a long time. So lots of good experience there. Leanna, our social worker, is here tonight. She'll be on the panel. She really handles the tough questions, the practical questions of the who, what's, whens, and wheres. So she's had lots of experience. We have a chaplain for spiritual support. The aides are fabulous. I know the little lady we saw here, our aide, I think, does some puzzles with her regularly. They've become really good friends. The aides can come and give a little bit of break for the caregiver when you may need to, be out for a minute. We have the very strong volunteer service that will come in and also provide those breaks for you as a family member and a caregiver. And then once your loved one has passed, or once you pass, you will know that we have a bereavement group that comes and follows you for the next 18 months and make sure you don't need anything, because once it's all over, it's hard. It doesn't just go away. We're available 24/7. We have someone on call 24/7. Call for anything. You may just need, am I doing this right? Am I not doing this right? Is this okay? Should I expect this? We will have somebody there to help you with that. We provide hospice in the home. We can provide it in a nursing care, extended care facility, a nursing home. We go there and we'll do the hospice care there. In the hospital, folks will come in if your symptoms, let's say you have a lot of vomiting and we're not able to get that under control, we may have to bring you into the hospital for a little bit to get those symptoms under control, back to the comfort piece there. There's also respite care available if you are your loved one's caregiver and you want to take a break or caregiving breaks down. We can do respite care. We can do that in the hospital, or sometimes we'll do that in an extended care facility also. So I think that I have hit all the yellow. Oh, no. Who pays for hospice? Big question. Follow the money, right? So Medicare covers 100% of most of the service that under the Medicare hospice benefit. That's at no cost to you. That's part of the Medicare hospice benefit. So nursing visits and the medical staff, aides, light housekeeping, your medications for symptom relief, medical equipment, hospital beds, oxygen, bedside commodes, chairs, pads, things of that nature, grief and emotional support services, the chaplain and spiritual support, our social worker. Medicaid usually covers the hospice fully. It is state by state, and then most private insurance plans also have a hospice benefit, but that's unique to the plan, so you would just have to know what your plan covers when it comes to that. I think I've hit all the highlights. So I get to do the fun thing and let you guys have a break for about 10 minutes, is that right? So you may...
Thanks for coming back. We're going to wrap up this evening here with a panel discussion. Give you guys some opportunities to ask some questions to our panelists. We do have a couple of questions that were left for us, so appreciate those. Any others that come up, you'll have the opportunity to share those. But before we get started, we'll introduce our panel, give them the opportunity to share a little bit about themselves before we jump into the questions. So first off, Dr. Merrifield.
Hi, yep, Dr. Merrifield. I'm a medical oncologist here at Schneck since August of 2021. Happy to answer any questions you guys have.
Dr. Pam Schneck. I've been a family doctor here since '99, so 26 years. And I've been the director of the hospice here. I know. It's weird since I'm 40. And I've been the hospice director since 2007, so 18 years as hospice director.
You guys know me. I don't have to. I'm Leanna Crenshaw. I've been with Schneck since over 25 years now. I worked over at inpatient for several years. I've been in hospice and home care since 19.
She's also 40.
I'm 35.
All right, well, we appreciate you guys being here and being able to answer some questions. I'll kick off with the first question here that was left for us. So if my doctor and the hospital has a copy of my advance directive, do I need to keep a copy of this as well? Take that.
I would say yes. Definitely. Because you might change computer systems. No, I think I think about this myself is like you really need to have it very available, like almost on your refrigerator, grab it and go kind of available, because if you land in the ER, that is your route into what it probably will be. I would want to rely on myself to have a copy of that available. So I would put it, everybody's got a magnet on the flip side of their refrigerator. I would put those papers there, but also keep a copy maybe in your safe or wherever you keep your safe papers. That would be my answer.
I would piggyback off that. I love the idea of keeping it on the refrigerator. Some of our EMS folks have been trained to look on refrigerators when they're in the home for these kind of documents. The other place that I tell patients is if you have a medicine cabinet or a medicine bucket, throw a copy in there too, because that's the other place that EMS and fire will look oftentimes as they're going out the house. They'll grab, if they see meds there, they will grab that and take that with them. So it's just another way to keep going. So. Anybody have a question, or do we want to keep going on the ones that we've got submitted?
Well, it's a follow-up question or maybe just open discussion, because there's a question about can people override. And if you are in the emergency room and we do not have a copy of those advance directives and a relative is with you, chances are the emergency room is going to default to that particular person. So where we get back to the idea of your loved ones knowing really what your values and your wishes are. I don't know if anybody's had that experience with something like that happening.
Yeah, I've certainly, in my time, done everything and only to find out that we weren't to do anything, and that's a really bad feeling. So, but it's just, I think you touched on it, and you touched on it too. It's a very hectic time, and yeah, in a perfect world, everything's right there and you need it, but that's not how it goes down. So, I would always have those papers with you, easily attainable.
This is kind of a piggyback off of that question. So this says, I have a blended family. If I don't appoint someone to be my healthcare representative, isn't it my oldest child's responsibility to do so?
No. First it goes to the spouse, right?
The spouse.
Current spouse.
Spouse.
That's what I do. Yeah. Well, I was married to them for 30 years and I know what they want. Well, I'm married to them now. And so
for 7 days, I know better.
But that's legally, it's the current spouse gets that top billing. And then I think after that is the oldest child.
Well, no, actually, it used to be, but Indiana changed it to where all children have equal standing. So that's why it's important if you have.
Which can be chaos.
Yeah, exactly. We ran into that about 15 months ago because there was a lot of sibling rivalry and there was a lot of disagreement. And it took several hours to sit that out.
Even though it is a difficult discussion to have, the more often you have that conversation, sort of the easier it gets, and the more you can put it out there. This is what I want. So if everybody has heard you say it, then they can at least agree, well, don't you remember when mom said this? Well, yeah, she did say that. Even if they don't agree, if they both heard you say what you want, then it's a lot harder to argue with each other if they both know what your true wishes are.
This question says, my mom died of cancer last year. She went to a lot of different doctors, but nobody had a conversation about hospice. Where should I have started that conversation?
You don't have to have that conversation with your doctor. You can call us and we can do a consult there, and Dr. Pam knows all the rules. It's not like we just randomly say you qualify for hospice. We went and saw a 90-year-old the other day that didn't qualify for hospice. You have to have a very particular set of diagnoses, symptoms. It's really more than we want to talk about today, but it is regulated. It's not just a random decision that Dr. Pam says, yep. So always, I wouldn't say I'm not discouraging you to go to your doctor, but go to your doctor and ask the question, is this right for us? I don't want to speak for the doctors in the room, but some doctors will be more apt to speak to you about your choices than others. I mean, we're all human. We have different ideas about things and how we present things. And so I guess along with keeping your advance directive, you own your medical care. So you can ask any doctor you want about that. It's very appropriate at any time to have those discussions about advanced directives, where you are in your disease processes, and what that looks like in the future. I think that answers the question. I'm not sure. Did it answer the question?
Yeah.
Well, and hospice has been around for a long time, and palliative care a number of decades ago grew out of the need for people saying, well, I've got this thing, specifically cancer. I asked Dr. Merrifield to speak about this, but I'm not ready for hospice. I want a full board. I want my breast cancer treated. I want my anything treated. I'm not ready for hospice, but maybe someday I will. Maybe Dr. Merrifield, you can touch on your experience with palliative care as an entryway into this kind of comfort management.
Yeah, so you know, for patients who have advanced cancers that may not be curable, you know, as their medical oncologist, I'm doing some symptom management and some palliative care. Sometimes I do need some help, and I involve, you know, palliative care specialists to help me as I'm managing cancer and focusing on those decisions and treatments and scans and all that stuff. They're helping manage anxiety, sleeping issues, depression, pain, and things like that. So I can work alongside palliative care specialists, and I really like doing that. I think it's very helpful for patients who are, you know, being treated with curative intent, who have cancer, for patients who don't have curable disease. Palliative care can be very helpful. Now, also for patients who maybe aren't interested in treatment for their cancer, or we've been treating their cancer and we've gotten to a point where we don't have good options that are going to be helpful, that is a point at which hospice should be discussed for most patients if the life expectancy is less than 6 months. An alternative to hospice could be to see a palliative care provider in the outpatient setting for that expertise in symptom management. So I don't know if that answered the question.
That's a great, you know, people even with not incurable cancer still might want to treat, because there's a confusion to touch on between palliative treatment for cancer and palliative care. Dr. Merrifield can explain the difference there.
Yeah, so we do, and if you read my notes, if you have access to, you know, like the documents and things, you might see that I will sometimes write, you know, palliative chemotherapy or palliative treatment for advanced lung cancer. And what that means in that setting is that we're not treating with curative intent. We're treating to help the patient live longer, live better, but we're not trying to eradicate the disease because we can't. So that is a palliative treatment for cancer, just means that it's not being given with curative intent, which is different than palliative care, which is supportive care, symptom management, pain control, that kind of stuff.
We got one more here, and then it's all you. Where should I take my advanced directives in the hospital once I have them finished?
I know. Help can be useful.
Health information.
Yep. So medical records, I think, is the perfect answer. Eventually, it will be you can submit those through the portal. But I think the other option to make sure that everybody's informed of the conversation is to make sure that it gets to your physician. So whoever that, if that's your primary care doctor or if you have specialists that you're seeing, like Dr. Merrifield or your cardiologist, those kinds of folks, be able to help from that standpoint too. So that's something to help on.
I got a question.
Absolutely.
I've worked with enough IT systems to know that if an upgrade, if you're lucky, if you get 85% of what you expected, who would we contact to find out if an advanced directive that we turned in 40 years ago is still out there?
Very good question. The
I
answer
turned
would be
it in
medical
40 years
records.
ago, it needs to be refreshed. You need a new one. Yeah. Look at that information again and fill it out fresh.
Yeah, so if I have two questions. One, if I was going to fill this stuff out and I needed help, is that an appointment? Can I make an appointment with my primary care doctor to do that? Or like, what's my next step after I leave here tonight and I decide I want to do this post-form?
I've definitely had that conversation with people. They brought, or they come and said, I've heard about this, and we'll print it up and fill it out in the office. I've had people bring it in and say, help me fill this out. Absolutely, we'll do that.
Is that a separate appointment? Like, would you prefer a separate appointment for that that's dedicated versus like tacking it on to the end of a?
Well, in an ideal world,
yeah.
in an ideal world, we just take care of one thing at one time, but that's not how the real world works.
No, it's
It's, well, we just spent the last 30 minutes talking about this. Oh, by the way, can we fill this out?
Yeah.
So, I mean, however you do it, we're going to get the job.
That is something. So, are both forms provided in primary care offices or at the oncology office? Is that something that? Okay.
Yep. So we have those forms, and we've helped the patients fill out those forms in our office too. A lot of times, just after a visit or something. So if it needs to be done, we'll get it done.
Yeah, people will bring up the conversation about, I was interested in living well. Tell me more about that. I'm like, here's what you need.
Yeah.
And Dr. Pam can back me up with this. The Medicare, in most circumstances, will pay for an advanced care planning visit with your personal physician. Now, I've had one time when in some Advantage plan they didn't, but by and large, you can have a dedicated visit with your physician only to talk about this stuff and have some time to get some extra time to do it. But it's worth, if you have one of these million Advantage plans, checking with them. But we do these. Not as many as we should, and sometimes I have done these at the end. But Medicare thinks it's important, so they do provide time to do this.
I have a couple questions as post. It said it has physician signature, physician APR, PA, healthcare professional other than the physician. Who would that be? Who would help fill these out if it wasn't a physician or a PA or a nurse?
In our office, we do, but you could have an LPNR, and you could have somebody else fill out the form as long as we are there for the signature. But most of the time, these conversations, people want their provider.
What, if they're here at the hospital, who would a social worker?
It could be a social worker, it could be one of the nurses. With hospice, a lot of times the nurse on admission will go over that form. Sometimes people want to think about it for a while and then I'll go in and
What kind of services do social workers provide for home health and hospice?
Well, one of the things.
Everything else.
What was the question?
Sorry. I should be repeating this. I apologize. The question was, what kind of services does the social worker provide through home health and hospital services?
So kind of like an umbrella of services. It could be financial needs, it could be emotional needs. sometimes the family can't handle the care that the patient may need at home, and then we have to work on alternatives, whether it's getting private caregivers in, we have resources for that, or getting to a nursing home, and sometimes that can be challenging because you're dealing with insurance and all the paperwork that goes with that. So just supporting the families through just different needs. Sometimes I do a lot of the documents with families. I also do POA. I'm a notary, so sometimes they need other documents taken care of. I can notarize. And a lot of FMLA paperwork, just all that tedious stuff that the family doesn't want to have to spend a lot of time on because they want to focus on try to take that burden off of them.
Yes.
So that you're not maybe redoing the paperwork every other day. I'll try not to make it like specific, but it kind of is to us. So if I name somebody as my healthcare representative, but I want that to be my husband. But clearly, he can make clear decisions for me, he just can't sign his name. So then it starts to get a little, so if I say my grandson is going to be the healthcare thing, and now I have some emergency, they bring me into the ER, do they have to track down grandson, or can my spouse make decisions that might, come about in a moment?
Good question. Did everybody hear that? So the question was, if you have designated somebody as your healthcare representative, but they are not present when you come into the emergency room, but somebody else, like in this case her spouse is, who makes the decision? Is it the spouse, even though they're not listed as the healthcare representative, or is it the legal healthcare representative?
Or the doctor.
Or the doctor in that too, if there is.
It's always been that we've always been told that we have on that paper overrides any of the hierarchy.
I think of override though more as if they disagree.
Right,
This would
right.
be, say you can't get him on the phone.
And that happens. So it would be just that. And hopefully, like I said, your grandson and your husband would be, it wouldn't be an issue. So.
But I was thinking when you said you could change them anytime you wanted, and I thought, well, that could kind of be a pain if I said, well, I'm going to make it you, but now you're not feeling so good, so now I need to make it grandson. Oh, no,
And you can make it an alternate.
Yeah.
So some people have a primary,
You can do.
and then you can have an alternate. So if X person isn't available, you have a backup person to be able to recognize. Yeah.
Yeah.
So you can definitely do that. Other folks, we've run into before, and I know Rachel has seen this in the emergency room, is I know I've got a form, we don't have a copy of it, but you didn't bring it with you into the emergency room, but we got to make a decision now. We are always going to lean towards life and restoring or resuscitating from that standpoint. And then once we get either a person on the phone, the form, some other advanced directive that kind of directs that care, then we kind of refocus what our care plan is from that standpoint. Good question. Other questions?
If you could create the most ideal scenario that you can, like what does that look like? Like is it that they've got the post form filled out, is it the advanced directive? Is it like what is the best case scenario when a patient comes in, or that you're, whether they're an oncology patient or they're a hospice patient, like what is the best case scenario as far as having all of that done? Is that mostly done with you guys, or is that more like a hospital question?
I think we've seen it occur in many forms. It might be with the hospitalist group, it might be with Dr. Maryville, it might be in your office. As far as how that comes down, I think the post form is the best way to know.
Wherever it's being done at.
Yeah. Would you guys agree with that?
Yes.
I think having that document completed, but then also having the conversations so that the people around you know what that document says and what your beliefs are. So something is like, well, because you can get so much, but there's always gray area. It's black and white until it's not. And if you've had those conversations,
Yes.
It's a lot easier to
And
interpret
I
that.
think the post form guides those conversations because like my mom would say, well, you know what I want. Well, no, we didn't talk about this. I'm not exactly sure what you want. So the post form can help you guide those more specific conversations about care choices. Because yeah, my mom would go, you know, but I don't think I do know exactly, you know. So it is good to have those specific conversations often so everybody hears the same thing.
I think I would add, yes, go ahead.
We have our bodies donated to the University of Indiana Medical Center, or university. And I'm wondering if something happens to us and we are brought to the hospital here, what happens next?
Great question. Did everybody hear that? So they have elected to donate their bodies to Indiana University and after they're passed. So what happens when they come into the hospital and they pass away from that standpoint?
Yeah.
Typically, I don't know if anybody else wants to.
Typically, there's a phone number that we call. Well, the family needs to know.
Leanna
That's your
doesn't
plan.
I can't hear you. What'd you say?
Then there's a phone number we call and alert them, and then they take it from there. They come and receive the body. And that kind of takes care of it. But your family needs to know that that was your plan so that it gets communicated to us so that we know. And typically it is. We've had that come up with hospice.
Okay, so we give, the person that sends them to the hospital gives them the information.
Right, like family, it's just, yeah, family with you, they would pass that information along. And yeah, we would get that information.
So again, that's great information to share with your primary care doctor, so that can be documented in your chart along with the advanced directives. So when that time comes, everybody knows that that's the plan. And even if we don't have that specific phone number, we can always reach out to Indiana University to their anatomic donation program to be able to do that. So.
Dr. Hartung mentioned a little extra space down at the bottom. That would be a great place to put.
Yeah.
I want my body donated to, and here's the institution, here's the phone number.
Yeah. So what Dr. Pam was talking about on the post form, the very bottom part down here says other additional orders. You can have that listed on there as well when you fill that out and have that submitted.
And from the hospice side of things, our case managers will work with the family to make a plan for what happens when the deceased, where do they go, what funeral arrangements, those sorts of things occur during your hospice care. So all that's taken care of, and we can make those phone calls for you when your loved one or yourself passes away. You would try to take that in the moment, things you need to do, burden away and handle that. So those conversations are had during the course of your hospice care too.
Sure. For Dr. Pam, because I'm curious to see her response in my role as a family medicine doctor as well, but not in the hospital. How do we as this group and this group going out to their family and their loved ones start to reduce the stigma of hospice? Because it still exists. People hear it and they go, that's not for me.
I wish I knew the answer to that, Dave. I would do it.
That's why I'm asking you.
Yeah. Making more programs like this, showing videos like that one. You know, Janet that's been on hospice for several months now. Yeah.
Has she been with us for since?
Probably. Yeah, just if you hear, somebody says, oh, they went on hospice, or they called in hospice. That's what I hear a lot. They called in hospice. Oh, they probably only have a couple days left. You know, voicing, you know what? I've heard that that's not really true. That, you know, hospice, you can be on hospice for months and months and months, and that's, you know, that's what we prefer, is to get somebody when they, you know, when they're no longer going to be, they don't want to do chemotherapy anymore, but they're not on death's door. They've just decided they're done with that.
Like we had a gentleman who went to, who did go see in Vegas? Do you remember? I don't, Metallica, I think it was. But, you know, it's not that you're going to die tomorrow. It's that you're going to choose how you want to do your last bit. You went to see Metallica. You know, we try to have people earlier so the symptom support is such that they can enjoy life. That's, I mean, quite simply, I mean, it's just manage the symptoms enough that you can have quality.
Still get some things off that bucket list.
Because when you get really sick, you may spend every day of your week going to the doctor, and then you're not here anymore. And like your last weeks were spent going to see Dr. Hartung. I mean, you know, it's a nice guy, but you know, it's that's what we try to provide in hospice, is that the living part, just like, you know, we saw in the video.
And I will try to bring it up, but I'm not always the best either. And so to empower you all and your loved ones to bring that up when it's appropriate. My practice people get hung up on the 6-month thing. And I tell them I mean, yeah, we have to say that. And it might be true, but it's not. We're not saying in 6 months you either get kicked off or, you know, somebody's going to come forward. And I had my longest patient was 2.5 years on hospice. So I think that's what we're trying to do here tonight is get people to understand what a breadth of services hospice really is.
So we have time for about 2 more questions. So yeah.
I'm just wondering about if someone does take hospice care, I assume there's someone that's assigned to oversee it, or I've heard some bad stories about, you know, but I'm just curious, how do they?
Yeah, so
Can you repeat the question real quick, just to make sure?
Yes, sir.
So the question was, who oversees the hospice care when a patient or family decides to move into hospice care? So who oversees that care?
Yeah, and the answer is we have a team. Usually the first point of care is going to be a registered nurse that goes to the home, explains, this is what hospice is, this is what we can offer, and then they'll communicate with me and say, here's the person I've met with, this is what their disease process is, and here's what their symptoms are. You know, I think they're appropriate for hospice, or maybe they're not appropriate for hospice yet. And we'll have that conversation, and I'll say, yeah, it sounds like they're appropriate. And they'll say, you know, here's what their needs are. They're having pain, they're having shortness of breath, they're having anxiety, whatever they are. What medicines are they on now? What medicines can we get rid of? Well, again, conversation with the nurse. That primary nurse visit lasts a couple hours sometimes.
Sometimes longer.
Yeah. I mean,
At least 2 hours.
Yeah, a couple hours to really just sit down and see what are the needs and what can we do, what do we need to do immediately. And then we have a nurse who will be the case manager. It's usually not the person who does the initial admission, but it's the person who's going to come into the home anywhere from 1 day a week. We have people who are pretty stable and they really only want somebody there once every 2 weeks. And so the nurse will come in once every 2 weeks just to sort of check in. But if they need something every day, they're there every day. And that nurse is usually the sort of the primary contact of seeing what the needs are and addressing that. But then she will report back to me, you know, pain is a little bit increased, what can we do about that? And we'll make adjustments there. She'll arrange with Leanna to say, you know, they've got questions about FMLA, you know, there's a daughter that needs FMLA to help. So she'll, you know, pull in Leanna for that. They're going on vacation, and they can't take this person with them, so they'll check them into the hospital. She might help with that. There's some spiritual needs. Maybe they've gotten away from the church and they want to get back to the church. We have a chaplain will come in and address that.
Do they make the decisions, or do they have to follow the wills or the?
No, those are all real-time decisions, and it's definitely a very fluid thing. So if they say, you know, I have more pain, and we do pain medicines, and then I'll get the feedback, and then there's, you know, 24 hours later, they're supposed to call back and say, how is your pain control now? And then report that back. So there's always communication between all the members of the team, the nurse, physician, the chaplain, the volunteer, the aide, social worker, and then we all meet every Monday for a couple of hours on a Monday morning, and we talk about all of our patients. We talk about half of them one Monday and half of them the next Monday. We go through with all the team in the same room. We talk about every single patient, what's going on with them, what's changed, what are we doing well, what needs work, what needs have they had that we've met, what needs do we anticipate they might have. You know, they're starting to decline. We're going to need to figure out how do we get somebody in the home to help take care of them? Some people might live alone, and they're not ready to go to a nursing home, they're not ready to have, but they're starting to decline. Then Leanna's gonna be, you know,
So does
figure
the
that out.
family then, once they're in hospice, does that family not really have any say or any input anymore?
And there's all kinds of input. They can be there, they can be, you know, during the visit, the nurses will usually say, I'm gonna come out on this day, family can be there. If they're in a nurse.
If the nurse says, I don't want family there.
I've
That's what
never heard
I've
a nurse say that.
I've never heard that happen.
I've heard bad experiences where the nurse rules like a dictator, and when a person died, the family member said her only concern was gathering all the prescription drugs before she left and calling to have someone come get the body. And they were so stunned that they regretted ever putting their family member on hospice. So, I mean,
Yeah.
I don't know them personally, but I've heard. So, I mean,
Yeah, that
That would not be our hope. Or,
If
not be
there
our
are
practice.
controlled substances like narcotic pain, you know, if those are in the home, yeah, we have to get those out just because that's a social problem, but that's not the primary concern.
but the hospital, hospice care, they pretty much take, I don't want to make it sound aggressive, but they pretty much take charge and take care of whatever needs to be done for the patient.
The patient can still see their primary care doctor.
And the patient at any time can say, I don't want this anymore. There's nothing wrong with that. I mean, it's not, you can change your mind. I mean, you can change your mind.
I'm gonna pipe up, and I don't know the experience of that family or that family member, but again, like I said earlier, sometimes we have to be the bad guy. If the dying person did not want their family there to see them die, maybe that nurse took on that role to say that they weren't allowed there, kind of thing. So that's, again, a possibility of what could have happened. So
I didn't know them personally, but the way it was described, you know, it caused concern.
And I'll be honest with you, not all hospice agencies are created equal.
yeah.
Because by and large, I'd say hospice is family driven, because they can dispense medicines and they can request this, that, and the other. They can call the hospice person and say, we're not doing so hot here. So I think 99.9% of the time it's
And
driven by the family.
our whole social support system around the bereavement program post is all for the family. You know, it's for the loved ones that are left behind to help bolster them and give them what they need. So it's very family focused, at least from our standpoint, on the care that we give.
Okay. Well, with that, I will turn it back over to Monica. I think is closing us out. Is that right? Thank you to our panelists. Appreciate you guys being here and answering our questions for us.
So basically, just make sure everybody has their packet. So kind of everything that we kind of reviewed tonight is in there. The post form is in there. All those different things that were talked about are in there. So this form is also in your packet. Okay, so this is all the different things, services offered by Schneck, right? So we've got primary care here in the professional building, internal medicine, hospice services, all these phone numbers. So this is all that can all be found in your packet. One other thing that is in your packet, nothing that we really necessarily talked about tonight, but through the foundation, we do have basically what's called value-based estate planning, and that's a free service offered through the foundation. So if this is a time when you're starting to get some things together and you're wanting to get your advance directive taken care of, but you wanting to also think about your estate, this would be something that is offered through the foundation. So you have a packet about that. The company's called Thompson and Associates, and we've had lots of families go through this program and help you kind of figure out what's important to you when you're planning where does your money go. So that's just another piece of this. It's nothing that we really talked about tonight, but that is a very nice service being offered through the foundation. So if anybody has any interest in that, certainly reach out. We can help you guide that. Again, that's offered at no charge through the foundation. or actually online as well. So you can go to schneckfoundation.org. I should put my glasses on. You also have a survey at your seat. We definitely want your feedback on this. This is a program that I think we're hoping that we can continue to do. So if you've got constructive criticism for us, let us know. Next time we'll maybe have them dessert, I don't know, but I'm just kidding. But anything that you think would be valuable to us, things that maybe you didn't hear, things that you did think were super helpful, we definitely value that feedback. So we do want to thank everybody for attending. Thank you to our wonderful panelists, Dr. Stone, Dr. Hartung, Dr. Fisher back there. We should appreciate everybody taking a couple hours out of your evening. But I think this was an important program, and again, part of that larger program covered it in control. So if you would be interested in My True Advantage and hearing about that kind of stuff, we've got some papers out there. That's the last piece of this program that is still left in October. So unless there's any questions or housekeeping issues, I think that concludes our evening. So make sure you take your packet, go through that. Fill out the survey if you feel so inclined, and we thank you for coming.
I did.